Welcome to Medical Rehab Matters. Today, we're talking with AMRPA's policy team. Kate Beller, President of Government Relations and Policy, Troy Hillman, Director of Quality and Health Policy, and Joe Nara, Director of Government Relations and Regulatory Policy. We want to thank podcast sponsor Bioventus for its support, and we'll be back after this short message. Bioness, a Bioventus rehab company, develops medical technologies which include neuromodulation systems, robotic systems, and software-based therapy programs that provide functional and therapeutic benefits for individuals affected by central nervous system disorders and orthopedic injuries to help return patients to active lives. Learn more at bionessrehab.com. Hi, Kate. I'm going to hand the reins over to you now.
Thanks so much, Patricia, and Happy New Year to all our listeners. I really appreciate everyone joining us today. As we head into 2025, today's episode is going to focus on our newly released annual policy priorities, which, as always, outline our key goals and themes for our legislative, regulatory, and advocacy agenda for this year. And while AMRPA will always be responsive to the day-to-day issues that our members report, our annual policy priorities are intended to highlight the critical challenges and opportunities that our leadership and committees have identified for us to answer the big questions for our field and to continue to champion the care that our members provide on a daily basis. The priorities can now be found on our AMRPA website under our advocacy header, and our team is always ready to answer any questions you may have on our list and our progress on each of our priorities. So with that, I'm going to turn it over to my colleague, Joe Nara, to touch on one of AMRPA's highest priorities for several years now, the review choice demonstration.
Thanks, Kate. And as Kate mentioned, we've talked plenty with this audience about the RCD and covered it in at least a few previous Medical Rehab Matters episodes. But we really see that in 2025, AMRPA will continue to lead the rehabilitation field response to this demonstration program. We hope you've appreciated and learned from all of the resources and guidance that AMRPA has provided over the past several years, especially since the demonstration began in Alabama. And as that demonstration continues currently in the states of Alabama and Pennsylvania and into future states in the coming years, we expect to continue AMRPA's robust support for our members. That includes providing information and timely updates on all of the new developments regarding the program, providing information that really helps individual members deal with any of the issues that they may be facing with the RCD, as well as continuing a close relationship and open lines of communication with the people who are operating the demonstration, both at CMS's Center for Program Integrity, as well as at the Medicare Administrative Contractors, or MACs, in each of the demonstration states. We find that having open lines of dialogue with those demonstration leaders allows us to quickly respond to any issues that our members raise in those states and try to ensure that all of the members that are impacted by this demonstration are working from a consistent and robust clarifications and guidance that CMS and the MACs may be issuing. We also are going to continue our advocacy towards ensuring a transparent administration of the demonstration and the results so far. As you may have heard, if you've attended our recent conferences, AMRPA has been able to share some relatively informal numbers about how the demonstration has unfolded thus far, but CMS has not been releasing public and regular data and transparency metrics about the program. And that's one of our key goals for this coming year, is to ensure that all of us, including AMRPA, our members, and other policymakers, have visibility into how this program is actually impacting patients and providers. And beyond that, we're going to continue to develop a consistent and compelling advocacy message on the RCD on behalf of the entire rehabilitation field. As always, our most important goal is to ensure that patient access is not interrupted. And with that, I'll turn it over to my colleague, Troy Hillman, to talk about another one of our priorities in 2025.
Thank you, Joe. And while this may not run on an annual cycle, we do work with the Medicare Payment Advisory Commission, or MedPAC, on an annual basis. Typically, their cycles run from September to roughly around a March report, as well as an additional June report that comes out. And as far as our priorities are concerned, we want to continue to engage with MedPAC, as well as offer them educational opportunities to learn about and really experience what is an inpatient rehabilitation hospital and what is the medical rehabilitation patient population. MedPAC typically produces payment recommendations that result in potential reductions in payment to inpatient rehabilitation providers. And we believe that we have the ability to really speak with them and engage with them to gain more understanding, not just with the commissioners, but also with the MedPAC staff, so that they understand exactly what inpatient rehabilitation is and why their recommendations may have negative impacts to those patients who really need and deserve care provided by inpatient rehabilitation facilities. So as part of our ongoing priorities, MedPAC is always a priority that comes up with AMRPA and our members. We look to facilitate any engagement opportunity as well as any discussion of MedPAC recommendations with the AMRPA Future of PAC Payment Reform Workgroup, as well as others within all of our other AMRPA committees. So again, looking for some robust engagement with MedPAC, talking directly with commissioners and possibly with the MedPAC staff to, again, make sure that inpatient rehabilitation hospitals are represented appropriately and that we can offset any recommendations that would suggest negative payment impacts to our AMRPA members. With that, I'm going to kick it back to Joe again to talk about some Medicare Advantage reforms and access to care issues.
Thank you, Troy. And this is another issue that has been a perennial inclusion on our policy priorities list for many years now, especially over the last few years. And so as we're continuing to see the continued growth of the Medicare Advantage program, with more than 50% of eligible Medicare beneficiaries enrolled in Medicare Advantage, we continue to see it as critical to ensure that all beneficiaries, regardless of their type of Medicare coverage, have robust access to inpatient rehabilitation care. And we do know that we are running into a new era in Washington with a new administration that may be approaching Medicare Advantage and the private Medicare program in a different way, but our goal remains the same. And so we are going to continue to advocate for meaningful improvements to Medicare Advantage policy, whether that's through legislation, regulation, or guidance, and ensure that all of our tools in our advocacy arsenal are being used to, again, make sure that access to care is robust, regardless of whether you're in traditional or Medicare Advantage. We're also going to continue to work closely with some of our partners across the post-acute care field. We've had some success in the past few years by working with our partners in the skilled nursing facility space, the home health space, the long-term care hospital space, and underscoring the importance of generally ensuring access to post-acute care in all settings in Medicare Advantage. And we're going to continue those partnerships in 2025 and beyond. And then finally, using data to support this advocacy message is always critical for any policymakers. And we'd like to thank the hundreds of AMRPA member hospitals who participated in our 2024 Medicare Advantage and prior authorization survey. And in the early parts of 2025, we're really looking forward to publishing the final results of that survey, packaging them together in a way that's going to be convincing to policymakers and underscoring both the concerns that people face today in getting access to care in Medicare Advantage and highlighting some of the solutions that our data can support, again, in order to ensure that anyone who needs care in an inpatient rehabilitation hospital can get that care. And now I'll turn it back over to Troy to talk about the quality reporting program.
Thanks again, Joe. One of the major factors and priorities for me as Director of Quality and Health Policy is really focused on the IRF Quality Reporting Program, or IRF QRP. One of the major priorities for AMRPA is to limit negative impacts and any unintended consequences as CMS continues to expand upon the IRF QRP requirements, as well as all of the data assessments that we're required to submit to Medicare on a daily basis. First and foremost, we need to look at last year, as of October 1st of 2024, IRFs are now subjected to a new requirement to submit IRF-PAI information for patients from all payer sources. Previously, we had data only collected or submitted to CMS for the purposes of the IRF QRP related to Medicare patients, both on the fee-for-service side as well as Medicare Advantage. However, this expansion is creating a lot of concerns across the AMRPA membership related to, different ways of assessing the patients, requirements to submit all of this data, and then ultimately potential 2% payment penalties that may be incurred for failure to submit data for any of these individual patients now that it's expanded to the all-payer population. So we want to produce data-driven strategies to really engage CMS on what are the impacts of this expansion of this requirement. especially related to some of the administrative burden related to untested and inappropriate data collection, especially for those pediatric patients, adolescent patients, and any other patients under the age of 18. We are looking to obtain some additional data to speak to CMS in more detail about these impacts and some of the negative consequences or unintended consequences that may have resulted from them expanding this data collection to the all-payer population. As I already mentioned, the risk of 2% payment penalties has expanded now that we've expanded to an all-payer population for submitting IRF-PAI data. But not only that, but we also have issues with some measures that are collected within the CDC NHSN portal, some of those vaccination measures and infection measures that we have in place as part of the QRP. We strive, as we've done the last few years, to really reduce or eliminate the risk to all AMRPA members for those 2% payment penalties. And we're going to do that through planning and education, as well as some additional legislative action, if possible, to try and limit or eliminate those reductions in payment that result from these IRF QRP requirements that are overly stringent. And then finally, we want to engage on the ongoing development and management of IRF QRP measures. AMRPA is very active with the Partnership for Quality Measurement. We do have a AMRPA representative participating, especially in their primer committee or their pre-rulemaking measure review process. We're also highly involved in the endorsement and maintenance process for any quality measures that look to be endorsed or that are changing their endorsement status. So we want to make sure that we're proactively engaging in these areas where new quality measures may come to the forefront and make sure our voice is represented well within those opportunities to discuss those measures and make sure that only any new measures that are under consideration are appropriate for those types of patients that we serve, as well as our providers, to make sure that their performance and the quality of care that is delivered is properly represented. With that, I want to now change course and talk a little bit about projects with the OIG and kick it over to Kate for additional information.
Thanks so much, Troy. So a lot of the issues we just covered, prior authorization, quality reporting, are issues that you hear about generally on a year-to-year basis when we map out our policy priorities. I'm going to cover a few that have really emerged in recent years that are presenting really, I think, interesting and exciting opportunities for the association. The first is this Office of Inspector General, or OIG, audit. For longtime AMRPA policy followers, there was a report that was released in 2018 that found that 84% of the claims reviewed by the Office of Inspector General, which is an oversight entity, 84% of the IRF claims reviewed were deemed inappropriate for IRF admissions from either a medical necessity perspective, a documentation sufficiency perspective, or both. AMRPA, as well as most other stakeholders in the IRF field, were really concerned about this result, didn't think it was accurate, thought it was yet again a misapplication of IRF coverage rules, which we see quite frequently in many contexts, including Medicare Advantage reviews and audits, et cetera. So AMRPA reached out to the Office of Inspector General. We relayed our concerns. We actually had a discussion with both the OIG and CMS where we had a review of specific cases. And there was, some recognition that perhaps another audit could help shine light on where both the OIG and the field, of course, could improve and yield more accurate results and better results in the years to come. So that audit is ongoing, and AMRPA has just, again, continues to engage with the OIG. We're not part of the report. We're not auditing our members, but we are there for the conversation about what recommendations the OIG could consider to improve its methodology, what the field could do to improve from things like a documentation perspective. And we look forward to seeing the results of that report sometime in 2025 or early 2026. So more to come on that front. Another priority that we have this year that really came to our attention in spring of 2024 is engagement with the Center for Medicare and Medicaid Innovation, otherwise known as CMMI. And CMMI is an entity that has been around and was created by the Affordable Care Act. And it gives CMS the authority to test new types of payment and coverage models that are intended to reduce Medicare spending while maintaining or even improving quality outcomes. CMMI's record has been somewhat checked. Some of the models have not gotten the uptake that they intended or the savings that they intended. But given the authority of CMMI and the important role that it plays in testing and modernizing the Medicare program, I think it's very important for AMRPA to partner with that entity within CMS and advance what we think are positive payment and coverage reforms in the post-acute care space. More specifically, in last year's inpatient prospective payment system payment rule, there was a proposal for CMMI to test what's called the TEAM, or the Transforming Episode Accountability Model. And this is another bundle payment type model that will include IRF services. I won't get into the weeds of it. We have a lot of material on our website. The long and short of it is that it, once again, will really drive post-acute care decisions on a cost rather than patient need basis. There's a lot more to come with this model. It's not ready to even take effect until January of 2026. So we have some time ahead of us to work with CMMI and ensure that if it moves forward, that patient access to IRF care isn't jeopardized on the account of this model. Moving on from the regulatory side to the legislative side of things, it's obviously a new Congress, a new administration, all starting in DC in January. And AMRPA has set out to really build our legislative champions. In the last few years, we've really seen a lot of our longstanding champions retire or leave Congress for other reasons. And really the time is ripe to look at our membership profile, see where the districts are that really correlate with really important congressional offices from this year, from a health committee perspective. And to help us with that, we're really excited that we've hired Alston and Byrd as our new legislative counsel. And they are off and running. I spent personally about 6 hours with them on Capitol Hill on January 3rd, which was also the very first day of the new Congress of this year. So we basically have done as much as we can as early as we can, and really encourage members to be part of our March 4th fly-in. I think that will be the best opportunity to really get in front of your members and their key staffers and educate them about what your hospital does and this value of services that you provide to your patients and those who work within your hospital. So very exciting time for AMRPA and our legislative strategy. So continuing to turn our policy wheel, we'll touch on some research now, and I'll turn it back to Joe to cover that.
Thanks, Kate. And this is an area that we're really excited for in 2025. AMRPA is launching a new and sort of reinvigorated research committee, and we're really excited to staff that committee up and have our first meeting in just a couple weeks from this recording. We already have a very robust roster of experts across the field representing researchers, clinicians, and administrative leadership. And we're really looking to employ research methods to really bolster our work for AMRPA. And so some of the things that this committee is going to be taking on include certainly supporting our policy and advocacy efforts. And that's going to be relying on those experts with research expertise in the inpatient rehabilitation field to develop and disseminate sort of impactful research that supports our value proposition for inpatient rehabilitation care. We're also looking to explore avenues to support and even conduct potentially our own evaluation and outcomes research to, again, really hit home how important it is to have access to inpatient rehabilitation care. We're looking to promote innovation in rehabilitation medicine and also disseminate some of the knowledge and best practices that our member hospitals, many of whom are conducting research already, are already sort of building in terms of best practices. And then finally, supporting and developing research capacity and expertise across the field. We know it's really critical to always be data-driven and to have a robust network of researchers, clinicians, and policy experts among AMRPA members and outside of our membership. So we're really looking to offer some training and development opportunities for both new and experienced researchers within the AMRPA spectrum. And so with this committee, again, really excited to launch it. I want to give a thanks and shout out to our two great and expert research committee co-chairs, Kelly Linden, who is an AMRPA board member and the CEO of Casa Colina Hospital in California, and her colleague, Dr. Emily Rosario, who's the executive director of the Casa Colina Research Institute. Dr. Rosario and Kelly have already been off and running with this committee, and we're really excited to work with them to push this new area of AMRPA's policy and advocacy agenda forward. And with that, I'll turn it back over to Kate to talk about a number of other issues that we have going for 2025.
Absolutely. And this is part of our broader efforts to advance in the inpatient rehabilitation field and support our members through our regulatory agenda, which I view really as the bread and butter of what we do as an association. And obviously, one of the most major things that we do during the course of the year is respond to the annual IRF coverage and payment rule, which we typically see sometime in March or April. And it's always an open question of what's going to be in there, whether it's going to be a pretty straightforward rule as we saw last year, or a rule full of things that we need to dissect and determine the impact on our providers, and most importantly, how that impacts patient access. One issue that we saw come up about 2 years ago was just a request for information, but involved the potential reform of the transfer policy. And again, not to get into the weeds, but we worry that expanding the transfer policy to capture home health care could have the impact of limiting patient access to either inpatient rehab or home health afterwards, or both. So AMRPA sent very robust comments to CMS, encouraging them not to pursue that or any policy that, again, would have the impact of limiting or restricting patient access to our hospitals when medically appropriate. And we were pleased to see it did not appear in last year's rule. Again, when CMS issues RFIs, sometimes that's it, and sometimes that's something that pops up in a year or 2 or 3. So something that's really top of mind going into this year's rulemaking, in addition to potential star ratings program, which Troy is going to touch on in just a minute. I'm going to turn it to Troy for a different issue involving the next generation of post-acute care reform.
Thank you, Kate. And while we'll touch on star ratings next, I know one of the other things that we look to do from a regulatory standpoint is make sure that we're anticipating any new recommendations or proposals related to post-acute care payment reform. A little more than a year ago, we did see that MedPAC did not recommend the unified post-acute care payment system or any kind of model for a unified payment system. We need to be prepared. We need to continue to engage with our stakeholders about any potential payment reforms. Again, focusing our attention on some of the payment reforms that have occurred across the post-acute care spectrum, notably changes in the payment models for skilled nursing and home health settings, as well as inform ourselves of any kind of policies that have impacted long-term care hospitals as well over the past few years. We need to make sure that we're in a strategic position to make sure that AMRPA is best represented and that the impacts to inpatient rehabilitation providers does not impact the access to care for those that deserve rehabilitation and really deserve that in an inpatient setting. So again, we need to make sure that we're prepared, that we anticipate what's coming next from a post-acute care payment reform standpoint. And again, our Future of PAC Payment Reform Work Group is really engaged in any kind of opportunities or any kind of proposals that come forward and discussing what's best from an AMRPA and from an inpatient rehabilitation provider perspective. And as Kate touched on previously, another thing we need to prepare ourselves for is for any CMS development related to IRF star ratings. So star rating programs are in place for other post-acute care providers, especially skilled nursing facilities, where those IRF star ratings really drive from a consumer standpoint whether or not a patient may actually, receive care in your facility or be referred to care in your individual facility. So we need to identify opportunities where we can engage with CMS. So they kind of put an RFI out there in the proposed rule last year and acknowledged some of the responses they got in the final rule last year. But really, we're not quite sure where CMS stands right now on the IRF star ratings program. And AMRPA needs to prepare ourselves and really engage with CMS on what level of development is this IRF star ratings program at, and how can we contribute to make sure that it's mostly representative of the quality of care that's delivered in inpatient rehabilitation providers and utilizes those quality measures or other factors in trying to identify what is a truly 5-star rating versus those providers that might be at a lower level. So again, engage with CMS, participate in any ongoing development, and focus our attention on star ratings to make sure that they don't disadvantage some of those AMRPA members and the patients that they serve and the quality of care that's provided. With that, I want to hand it over to Joe to speak about some physician payment reform and prioritizing the rehabilitation voice when that debate occurs.
Yeah, thank you, Troy. And as many of our members unfortunately already know, physicians, including rehabilitation physicians, as well as therapists and other providers who are paid under Medicare Part B, have seen, unfortunately, a steady decrease in their payment rates for the last several years, culminating most recently in about a 2.8% cut that went into effect January 1st of 2025. For those of you that were following the government funding debate at the very end of 2024, we thought and expected that there was going to be at least some mitigation of this provider payment cut. But unfortunately, that was dropped out of the year-end government funding deal that came into play. And so currently, again, Medicare Part B providers are facing about a 2.8, 2.9% cut for all of their services with service dates after January 1st. We do expect this to be on the table for Congress to address very early on in the 119th Congress, which Kate mentioned just convened a couple days ago from this recording. And so we are going to be working very closely with our new legislative council, our partners across the field, and members of Congress to ensure that, number one, these payment cuts are mitigated or erased as much as possible for the sort of short-term fix. But also longer term, we do expect that this Congress is going to be looking at broader reforms to the Medicare physician fee schedule and how payment is determined. We really are looking forward to be involved in that debate and, again, ensuring that rehabilitation voices are heard. So certainly physicians and rehabilitation physicians, as well as speech language therapists, physical therapists, occupational therapists, rehabilitation nurses, all of the providers that work in our facilities that do see their pay come from Medicare Part B, we want to make sure that they are recognized for their services and paid appropriately to ensure robust access to care. And then finally, I'll turn it over to Kate for one of our other legislative goals in 2025.
Great. Thank you, Joe. And this is something that's been on our radar for a while. With every IRF coverage rule, we're always looking to see if, as the population ages and technology advances, if certain common sense modernizations may make sense as they apply to the IRF payment and coverage system. And one of those rules involves the 3-hour rule. AMRPA supported a bill the last few Congresses that would expand the types of therapies that count towards the 3-hour threshold. We recently were involved in a workshop with numerous other IRF stakeholders that explored other avenues of reform. AMRPA isn't committed to supporting necessarily anything other than what we've lobbied for in Congress, but always look forward to being part of those discussions. And the outcome of that workshop, which was, again, the Levitt Partners workshop, we'll probably continue discussion with association members in early 2025. So again, it's just a flurry of activity right now. Patricia, as you can see, there's certainly no shortage of planned activity in 2025, and there's always things that pop up on a week-to-week or even day-to-day basis during the year. So we certainly have our work cut out for us, but we're really excited and look forward to working with all our members on this ambitious agenda.
Well, I want to thank all of you for today. I think this was really informative, and it's an important episode for us to start the year off with. The policy priorities are always an important part of the beginning of the year for AMRPA, spreading the message of what we're working on this year. I also want to say, all good things have to come to an end, and that includes this season of our podcast. And this is also the final planned episode of Medical Rehab Matters. We want to thank everyone who's participated over the last 4 years, either as a guest, a co-host, or a sponsor. Certainly, Joe, Troy, and Kate have been instrumental in the podcast for the last few years. But we hope our podcast paths cross again in the future and that we've informed, educated, and spread the message that medical rehab matters. Bioness, a Bioventus rehab company, develops medical technologies to support recovery for people living with the effects of stroke, brain injury, MS, and other conditions. The Bioness portfolio of products includes functional electrical stimulation systems such as the L300 Go-Drop foot system and the H200 wireless hand rehabilitation system. The Bioness Integrated Technology System, BITS, is a software-based therapy platform that uses an interactive touchscreen display to challenge, assess, and track vision, cognitive, motor, and balance deficiencies. The Vector, Gait, and Safety System is a ceiling-mounted robotic dynamic body weight support system designed to accelerate physical rehabilitation of patients with severe gait or balance impairment. Bioness combined portfolio helps drive efficiencies and improve patient outcomes for healthcare providers. Learn more at bionessrehab.com. This has been Medical Rehab Matters, a podcast by the American Medical Rehabilitation Providers Association. Special thanks to Diamond sponsor Bioventus and Platinum sponsors PAM Health and Select Medical. To learn more about inpatient medical rehabilitation, visit us at amrpa.org.